to 4, Endometrialn Regeneration, which is start.
Thank you, Chairperson. Thank you, Dr. Bashiri, Dr. Mala, for organizing this conference where people can present their research work. Very important and a very interactive sessions where we can ask questions without inhibition and get our doubts cleared. Congratulations for this conference, and I start my talk with stem cell based therapy and endometrial regeneration. Yesterday I had given a talk on regenerative therapy in RPL. If unexplained infertility with low AMH can be proven that low AMH may be one of the responsible factor, how the rejuvenation of the ovary with either PRP or stem cell can help bring out good quality oocytes and treat that RPL. Today I speak on this endometrial regeneration. Endometrium, one of the most important components for embryo implantation, pregnancy maintenance. 7 mm is what is the cutoff. Basal layer, which is very rich in reactive oxygen species, and that is detrimental to the implantation and development of the embryo. Hence, we don't want that thin endometrium. What could be responsible? Maybe the malfunctioning of the endometrial stem and progenitor cells of the incompetent thin endometrium could be the attributing cause, and definitely thin endometrium can be a cause for increased rates of miscarriages. There are irreversible damages to the endometrium due to miscarriages, termination, repeated DNC, any repeated uterine surgeries, and intrauterine infection. And the treatment protocols we have is from tamoxifen to reduce the increased lining, acupuncture, pentoxifylline, low dose HCG, and luteal gonadotropin releasing hormone in low dose extended oxygen therapy. Hysteroscopic adhesiolysis, whenever there is a lot of synechiae, is considered the gold standard of treatment. But let us look at the new modality of regenerative medicine. Even if you do hysteroscopic adhesiolysis for intrauterine synechia, there is re-adhesions in 62.5% of cases in severe IUA. The main Asherman syndrome, what we discuss, is the infertility, recurrent abortion, hypomenorrhea, pelvic pain, and menopause. I'll be touching the adhesions, Asherman syndrome, and also endometrial atrophy, how the stem cells can help. So, recurrent pregnancy loss is one of the effects of damaged thin endometrium, and cell therapy has been considered ideal alternative by employing either stem cells, platelet-rich plasma, and growth factor. It is an emerging technology and may play a pivotal role. The basalis layer, composed of the stroma, basal region, vasculature, and lymphoid aggregates, and the functionalis. The basalis layer never shreds, but it can help regenerate, repair the endometrial wound after the menstruation and rebuild the functional layer. Look at the endometrial stem cells. They are located in the basal layer, source of progenitor cells to form the endometrium. And endometrium progenitor cells can rapidly replace the functional layer. They have a potential for high proliferation, self-renewal, and differentiation. If you look over here, where are the stem cell niche in this? It is surrounding the spiral vasculature. So these are the endometrial niches which are present surrounding the spiral vasculature, and this stem cell niche is a very dynamic structure. It has cellular components, secreted factors, extracellular matrix, environmental signals, physical parameters, and bidirectional regulation. So by giving this stem cell therapy, you can achieve satisfactory results by reducing endometrial fibrosis, repairing the damaged endometrium, and improving the uterine receptivity. The stem cells repair endometrial injury mainly due to their differentiation ability, paracrine activity, and immunomodulatory effect. If you see this diagram, whenever there is a stem cell therapy done, there could be differentiation into epithelial endothelial cell, vascular endothelial cell, endometrial stromal cell. The paracrine effect is also useful, and the immunomodulatory effect is also useful. The mechanism is mainly cytokine induction, growth factor production, NK cell activity reduction, and improving Treg and Th2 cells and reducing the Th17 and Th1, which are the harmful cells. What happens when you put the stem cells? It homes it into the damaged tissues, then differentiates and integrates into somatic cells with non-tumorigenic effect as you are using adult stem cells. And the microenvironment is also improved, and the transplanted tissue can then restore the endocrine function by secreting anti-inflammatory factors, as I suggested that the Treg cells will increase, Th2 will increase, and Th1, T7 will reduce. You can see on the other side that there is a thin endometrium and the implantation failure adhesions, but after stem cell therapy, the endometrial thickness is increased and the embryo can be implanted. Either you give stem cells, PRP, or scaffold structures which help in delivering the drug or the stem cells over there. Which are the stem cells which are useful? Embryonic we don't use. The adult stem cells, what we use is bone marrow derived stem cell. Umbilical cord is a very rich source of mesenchymal cells, but unfortunately in India we are not allowed to use umbilical cord stem cells. Menstrual blood stem cells we are trying to develop, not very successful so far. Endometrial stem cells from the endometrial tissue, but here the patient has a damaged endometrium and the amount of tissue you can get is very minimal, so not useful. Adipose is also one source. Now currently various clinical trials have been enrolled where they are going to show the potential effect of the stem cell in repair of the endometrium in application not only for Asherman's but endometrial atrophy. Scarring will improve, menstruation will improve and enhance the fertility. Surveil and colleagues have proved that human CD133 plus BMDSCs with either in the intrauterine or tail vein injection in urine model could engraft the endometrial vessels and promote endometrial regeneration. Now I'll talk about the bone marrow derived stem cells. They contribute a lot. They can travel to distant organs. Even the murine and human endometrium, it exists. Both could be inferred that they have a potential for serving as a reparative cell source for the reproductive tract. Regional signals of injury probably play a significant part in mobilizing the BMDCs to the injured tissue. And it has been demonstrated that ischemia reperfusion injury in the uterus enhances the migration and engraftments of the BMDCs in the endometrium. Number of experiments have been done either with PRP or with bone marrow derived stem cells, adipose, umbilical cord in the animal models as well as the human models, and they have shown successful result. And they have been injected directly into the uterus, subendometrium, hysteroscopically, or around the uterine artery spiral arterioles, that is the tail vein in the murine models. Intravenous does not play a significant role. So here again you see that the thin endometrium is there, and after the stem cell therapy, the growth factors are released and there is a thickness of the endometrium. So let us look at the PRP and BMDC. I am also including PRP in this. This is the preparation which I showed yesterday, that for just intrauterine installation we prefer PRP when the endometrium is made more receptive, not only very thin but where there is recurrent failure. About 10 ml you take in 2 test tube and then you centrifuge it, take the puffy coat, again centrifuge it, dilute it, and for intrauterine you may just need 0.4 to 0.5 ml, but for hysteroscopic you may need about 3 ml. The bone marrow preparation is what I am going to concentrate more now on. The patient is counseled thoroughly that it is an experimental procedure, and the pre-workup is that once the audiovisual consent is taken, they are taken in the observation room, about 2 liters of oxygen for 30 minutes, injection of vitamin C 150, injection glutathione, and an antibiotic is injected, and then the patient is taken up for the bone marrow aspiration. We do all the bone marrow aspiration under general anesthesia because we don't want to give any pain. The needle is very thick and it is mainly from the anterior iliac crest that we take up. And once about our target is about 50 ml, we want to take it. 80 is best, but anything more than 30 is very good. Along with it, when the patient is admitted, we also collect blood for platelet-rich plasma because it has been shown that in vitro and in vivo, when you grow the stem cells on a platelet-rich plasma base, the growth is even more and the growth factors are even better. This is the manual preparation. We still prefer the manual preparation. for the bone marrow derived mesenchymal stem cell separation. And what the method for instillation is three, whether we are doing PRP or bone marrow. It is intrauterine, where it is simple injection to 4 ml, 0.4 ml 2 to 8 days before the IUI or embryo transfer, or hysteroscopically when you are taking up the patient for electrolysis. You collect the blood, it takes about 45 to 50 minutes. Then you activate the PRP. Activation is very important because the platelet granules, the platelet count should triple. The platelet granules should be given a mechanical stimulus or a chemical. We prefer the mechanical. Dip it in liquid nitrogen, thaw it, dip it, again thaw it, and then you inject it. 0.7 ml with the egg retrieval needle. Only we do it in the two lateral walls and in the two anterior and the posterior wall, and you wait after injecting very slowly so that there is no leakage and it doesn't come back. But this is what has interested me the most for the patients with extremely thin endometrium, tuberculosis patients, where there is total scarring of the endometrium, hardly any menstruation, just brownish discharge off and on. Whatever you do, number of hysteroscopies, extended estrogen therapy, whatever you give to the patient, the endometrial lining does not develop. So let us look at this bone marrow derived stem cell instillation into the uterine artery spiral arterioles. The stem cell therapy targets the endometrial niche, which I discussed, with the ultimate of replenishing the cellular compartments of the functionalist layer and offering a promising treatment for Asherman syndrome and endometrial atrophy. It is very important to understand, as I showed in the diagram, that in humans, the endometrial stem cell niche is located at the endothelium of the spiral arterioles in the basal layer, and CD133 was said to be useful, but in the bone marrow you have all the CD133, 90, 45, 34, so they act together. So it's not only CD133, you can use all the stem cells that are there in the bone marrow to promote it. What is the action? When you use the autologous endometrium, but we are using the bone marrow derived stem cell, they will transdifferentiate into endometrial stem cell. There will be activation of endogenous endometrial stem cell. The stromal stem cells also will develop, which reside close to the endothelial cells in microvessel, both basalis as well as the functionalis layer. So they are CD44, 73, 90, 105, etc. The endothelial cells also will grow, which reside in the vascular endothelium of the basalis, and the epithelial progenitor cells. These are very important cells, and their dysfunction is one of the reasons for thin endometrium, resides in the base of the glands in basalis. And then there is secretion of the paracrine factors, which will cause immunomodulation, angiogenesis, antifibrosis, anti-apoptosis, and all this lead to endometrial regeneration with improved receptivity and restoration of fertility. So how we started? We got the approval from the Institutional Ethics Committee, a certificate from Department of Health Research, certificate of good laboratory practice. This is the OT where we collect the stem cells, the stem cell lab, but now we have a bigger lab, the cath lab, the biosafety cabinet, and the other. This is the preparation manually of the stem cells. Each and every stem cell that is prepared, later on counting is done, what is the number of the CD cells. But before injecting in the patient, at least the virus panels are run on the collected, the stem cell is then put for culture for 24 hours. In India, we are not allowed to culture and passage and then put the stem cells. As a rule, we cannot use any stem cells that has been chemically treated or passaged. Autologous stem cells immediately taken, and without any chemical treatment, we can put it back in the patients. So these are, unfortunately, we have do it before, only the virus panel we can get before we inject it in the patient. This is the cath lab setup, and this is how the procedure starts. What we do in cases of very, very thin endometrium, that once the patient gets admitted, we take the blood for platelet-rich plasma. We prepare that by the time the patient is getting the oxygen and the pre-bone marrow cell aspiration treatment. Once the patient is taken under anesthesia for bone marrow aspiration, once it is done, we take her for hysteroscopy under the same anesthesia. Adhesions are removed, and the platelet-rich plasma that we have, some is stored for the bone marrow growth and the others is injected in the 4 wards. Once that is done, and in about 1 hour and 45 minutes when the stem cells are ready, we take the patient into the cath lab. Here it is done under local anesthesia from the femoral artery. The femoral catheter is passed, and once the femoral sheath and the femoral catheter pass from one femoral artery, it goes to the opposite internal iliac artery, that is the hypogastric artery. As a rule, one of the doctors from our team has to be present when the stem cells are being installed, because we have in the same, our own hospital, the 3 departments. So, opposite internal iliac you go. From there, the radiologist will go to the uterine artery. By fluoroscopy, he will identify the uterine artery. Microangiocatheter is passed. You can see that, and once the microangiocatheter is passed and the uterine artery is cannulated, the bone marrow derived stem cell concentrate, about 2 ml, is injected in both. So from right femoral you go to the opposite left and inject it in the opposite left uterine artery spiral arterioles, and from the left femoral artery again you go to the right and inject it in the right spiral arterioles. You can see here that we have passed the catheter, the microangiocatheter is going, identifying the uterine artery and cannulating it. In the next I will show you the injection of this. You can see literally the spiral arterioles around which it is going, and again with a dye test it is confirmed that it has reached there. Somehow, what happened? Okay, now it has gone, and now you can see beautifully it has gone inside the spiral arterioles. So, this is the full procedure which I explained to you. Post catheterization and the procedure, about for 6 hours, huge pressure is applied on both the femoral arteries. Patient is in the ICU, we apply the stent pack, and then after that 6 hours the patient is in the observation ward, and the next day the patient is discharged. So in 2019, January 16, first 3 patients we enrolled as an experimental base, tuberculosis patient, all 3 of them, and one had also myomectomy. This first patient had hardly any menstruation, and this case was reported in the clinical and experimental reproductive medicine, and this 26 years old came to us with very refractory endometrium, brownish discharge off and on, or no menstruation, I think amenorrhea for 1 year. She had 3 failed IVF cycles. She was suggested surrogacy. With hysteroscopy, we did subendometrial PRP. We ourselves tried one IVF, but that also failed. And that's when she left us after 2017. But 2018, we recalled her that this is one procedure if you want to try, because they did not believe in surrogacy and she could not go for surrogacy. She immediately agreed for this experimental procedure. We did this in her, and then she was put on the hormonal treatment. For first 2 months she had very good menstrual cycle, then there was discharge and spotting. After that, in May she could develop a 7 mm lining. This was the first installation that we did in her, and that time to identify the uterine artery, we had put the Lish-Wilkinson cannula. I can show this, yeah. So because the radiologist wanted to be very sure, that is the only time we put it. After that he could identify on his own. And then this was the development of the lining, and we were very happy with it. We transferred the embryo, and in February, the first cycle she conceived, and she delivered a healthy baby. After this patient from Bangalore had her embryos frozen. She had 1 missed abortion, a DNA done, and her lining did not develop. Endometrial, subendometrial, PRP, number of hysteroscopies were done there, but her frozen embryos were there. She came to us, we suggested this procedure, we did this procedure in her, the embryos that were frozen for 1 year. We did it in March. In April she goes back in July to Bangalore. Because of COVID, she was stuck in Anand, and that's why we got this opportunity to do it in hers. The first cycle itself, she developed good endometrium. The doctor transferred 2 blastocysts in her, and she delivered healthy twins. A doctor who never believed in stem cell therapy asked me for the procedures and guidance how to go ahead with it. Another patient, 37 years of age, again tuberculosis, very thin endometrium, history of DNA, and we did this procedure and she could develop 7.5 mm, 4 to 5 months. We transfer only after 2 cycles, but in 4 to 5 months we have seen that we do get good results, and the first patient after the delivery has regular menstruation with regular blood flow even today. Embryo transfer was done, twins delivered. So after this we piled up our patients, and first 12 patients pilot study we published in the Journal of Regenerative Medicine, where we had done this treatment, and to our surprise, when we were installing the bone marrow derived stem cells, we could find absent uterine artery, hypoplastic uterine artery, tuberculosis or any infection caused severe endarteritis. And there was one patient, the radiologist could not cannulate the uterine artery at all, and she was negative. Out of these 12 patients, 2 delivered twins, 1 delivered a single, there is 1 ongoing pregnancy, 1 had a negative result, and 1 opted for surrogacy. The remaining are still trying. So it was quite interesting that how we are not aware the status of the uterine artery and how the stem cells could be regenerated if a proper uterine artery cannulation and spiral arteriole and endometrial stem cells are, when you push it, it goes around the spiral arteriole where there are the endometrial niches, and once these niches are injured, the stem cells are attracted and they get homed in these niches, and then they start functioning. So our paper concluded that Asherman syndrome and endometrial atrophy due to various causes do not hold good prognosis. Gestational surrogacy is the only option, but stem cells have shown promise in treatment of endometrial factor, and to the best of the knowledge, this was the first publication where bone marrow derived stem cells were used in the uterine artery spiral arterioles. We got our inspiration for Carly Simon's EV's paper, where they had used the peripheral blood after mobilizing the stem cells by giving GCSF injections, by plasma apheresis, and they had done 18 patients, 16 were included, and they had 7 positive, 3 delivered. In our study, out of 12, 1 did not get a good result because we knew we could not cannulate the artery. 1 opted for surrogacy. So out of 10, we already had 4 deliveries, 3 deliveries and 1 ongoing pregnancy. Today we have a data of 30 patients, where in 2019 we did 5, because whenever we start a new protocol or new therapy, we have to be very careful that what is happening to the first 4 patients, and then we get inspiration, and with good results we want to do more patients. 2019 we did just 5, 2024, 2021 we did 6, last year we did 12 patients, and this year by January end we have already done 3 patients, and today 1 more procedure is happening at my center. Because India is a country of tuberculosis, and the tuberculosis patients have very bad endometrium, they are almost ruled out and people feel they'll never get a result, but this therapy could be a boon for them. Out of this 30 patients, now 6 have delivered, 2 ongoing pregnancy, 3 had negative outcome, and the others are awaiting treatment. This is the latest stem cell lab in what we have, which is a state of the art, because now in India also there are strict rules and criteria and guidelines coming up for the stem cell therapy, where we need to have a class 100 unclassified, classified, with all the equipments what we need for the stem cell separation. There are biometrics, only limited number of people could enter inside, and all the samples should be preserved. After, we have to preserve a little sample to find out all the quality control checks, the hematological checks, the HIV, HBsAg, hepatitis, all this, and even they want chromosomal marker tests also. Normally that is after 3 passages that the stem cells become chromosomally, after 7. Up to 3 they are good for allogenic use, 4, 5, 6 you have to do all the studies, and 7 onwards there are a lot of chromosomal abnormalities also in the stem cells. So this is the stem cell which has got latest 2 months back permission for manufacturing autologous stem cells, that is for Form 29, and that too restricted bone marrow for reproductive medicine and infertility. So this is the whole where we do the quality control, we do the hematology, and finally this is the lab exit that we have. Now the scaffolds also, which we are trying to work on, the hydrogels are the most important, which can deliver the drug or the stem cells, and the scaffolds and the hydrogels. Hydrogels we are trying to work on. So basically, to conclude, I will say that endometrial injuries due to inflammation, infection or abortion has the option of pharmacotherapy, uterine stents and hysteroscopic adhesiolysis, but they have their limitations, and stem cells seem to be one therapy that is quite promising in such patients. Umbilical, bone marrow derived stem cells, menstrual stem cells and endometrial, if you get that material, the stem cells target the endometrial niche with the ultimate aim of replenishing the cellular compartments of the functionalis layer, especially for Asherman's and endometrial atrophy, and the remarkable regenerative capacity of endometrial stem cells offers definitely a promise for the regenerative medicine due to endometrial disorders, and the biomaterials such as nanostructure, lipid carriers, hydrogels, scaffolds, which are capable of promoting stem cell or drug delivery and improving the outcomes of stem cell therapy could be the future. Thank you.